Yeah, yeah, going to analyze urinary retention and incontinence and its relevance to psychiatry. Moderator is Dr. Abhishek. Firstly, I will be discussing micturition reflex. Then we will discuss what urinary retention and incontinence are and what are their management. And then we will come to the part of its relevance to psychiatry. So micturition reflex when the urinary bladder fills up to 300 to 400 ml, the stimulation of sensory stress receptor that are present on the wall of bladder occurs. Efferent impulses pass via pelvic nerve, then it reaches the sacral segments of spinal cord and synapses with the post ganglionic neuron. Efferent impulses via pelvic nerve causes contraction of detrusor muscle and relaxation of internal sphincter, and then flow of urine occurs in the urethra, and stimulation of stress receptor present in urethra occurs. It's an efferent impulses via pelvic nerve, and inhibition of pudendal nerve occurs, and relaxation of external sphincter occurs, and voiding of urine is there. So urinary retention is inability to void even when there is urge to void. It is basically of two types, acute and chronic. So acute being the most common. Causes of urinary retention may be outflow obstruction or neurological disorders. Outflow obstruction could be because of benign prostatic hypertrophy, urethral stricture, or infection leading to inflammation. Neurological disorder like Parkinson's disease or diabetic neuropathy can lead to urinary retention. Diagnosis is mainly focused on the basis of history. There may be a history of drug intake, and we have to check for residual urine. That can be done with the help of USG scan, and by inserting an intermittent straight catheter. The amount of urine left in the bladder, residual urine, should be less than 50 ml. Now, urinary incontinence. It is involuntary loss of urine from the bladder. There are four major types of urinary incontinence: stress incontinence, urge incontinence, mixed incontinence, and overflow incontinence. Stress incontinence is characterized by urine leakage secondary to abrupt increase in intra-abdominal pressure that might be because of coughing, sneezing, or laughing. Urge incontinence, it is involuntary voiding of urine preceded by an urgent, irrepressible need to void, often termed as overactive bladder. Mixed incontinence is combination of both stress and urge incontinence. Overflow urinary incontinence is urinary leakage secondary to urinary retention with bladder distension. This may be caused by structural abnormality of urinary occluding the normal flow of urine or weakness of the detrusor muscle. Now, assessment and diagnostic findings and in case of urinary incontinence, a thorough history is necessary, which includes a detailed description of the problem and history of medication use, the patient's voiding history, a diary of fluid intake and output, a bedside test may be used to determine the type of urinary incontinence. Urinalysis and urine culture are performed to identify hematuria, glycosuria, pyuria, bacteriuria, all of which may be may identify the causes of urinary incontinence. Management of acute urinary retention. Patient has to be transferred to acute medical or urological services. Once the retention has been revealed, now we have to treat the cause or precipitant. If it is due to psychiatric treatment, rationalization of treatment, that may be drug reduction or switching treatment to an agent that is less anticholinergic active may be used. If the effects of psychiatric treatment were indirect but related to a drug that is to be continued in the further treatment, then the side effects of the drug are to be treated. For example, clozapine causes constipation, which in turn precipitates acute urinary retention. So management of urinary incontinence. There are two types of management here. Non-pharmacological interventions and pharmacological interventions can be used. So coming to non-pharmacological interventions, where psychotropic medications are implicated in urinary incontinence, we have to simply observe the progression of symptoms. It may be transient and resolve spontaneously with time. Simple lifestyle modification can be suggested. Like in cases of nocturnal enuresis, we can suggest the patient to reduce the fluid intake at the time of eating and advise reducing the amount of caffeine and alcohol consumption. And use of absorbing pads or protective undergarments can be done. And pelvic floor or bladder training may be provided to the patient. Now, pharmacological intervention. We have to consider the dose reduction or cessation of implicated psychotropic medication. If nocturnal enuresis occurs during clozapine titration, consider slow rate of titration, take evening clozapine dose earlier, or if tolerated, wait dose such that more is given in the morning. Ideally, stop any other co-prescribed antipsychotics. Treat the comorbid constipation. For perimenopausal women with stress or urge incontinence, topical vaginal estrogen can be used. Duloxetine may be beneficial in the treatment of stress incontinence in women, and in men with BPH may benefit from anti-adrenergic drugs like doxazosin, tamsulosin. Anticholinergic agents like oxybutynin can be used in treatment of urge incontinence. Desmopressin, which can be given orally, sublingually, or also can be used as nasal spray, can be used to manage both the urinary incontinence and nocturnal enuresis. Now, its relevance to psychiatry. Psychiatric medication represents a key cause of acute urinary retention in patients with serious medical conditions. Due to higher prevalence of type 2 diabetes mellitus in psychiatric patients, autonomic neuropathy can precipitate urinary retention. So these are the drugs that are associated with urinary retention. Drugs which mainly have anticholinergic effects, like antipsychotic drugs, antidepressants, antispasmodics, antiparkinsons, atropine, and others. So antipsychotics differ in the terms of their anticholinergic activity, which may play a role in relative associated risk of acute urinary retention. Inhibition of noradrenergic reuptake and central serotonergic effects have been implicated in the mechanism underlying antipsychotic induced acute urinary retention. Retention has been reported with phenothiazines like chlorpromazine, haloperidol, olanzapine, risperidone, and ziprasidone at higher doses. Of all the antidepressants, tricyclics are more commonly associated with urinary retention, in particular amitriptyline and imipramine. Episodes of acute urinary retention have been reported with selective serotonin reuptake inhibitors like escitalopram. Antipsychotics have the potential to cause urinary incontinence. There is a strong association between urinary incontinence and clozapine. Nocturnal enuresis has been reported in patients up to 41% of clozapine-treated patients. Antidepressants, namely SSRI, have been associated with urinary incontinence. Now, this is a flow chart showing the triggering in case of nocturnal enuresis. Since it is mainly because of clozapine, so we have to we can take maybe two measures: non-pharmacological or pharmacological intervention. It has been earlier discussed by me. So if it is not caused by clozapine, consider alternative diagnosis and refer to primary care or urology. These are the references.
Good morning to all. Today I'm Mansi Goel going to present on the topic alcohol and physical health under the guidance of Dr. Anush. Alcohol or ethanol is the most commonly used drug in the world. For most people who consume it, alcohol causes little or no harm. However, alcohol is a toxin with the potential to damage multiple organ systems. Alcohol content in various beverages. Brandy contains 40 to 50% of alcohol, whiskey 40 to 55%, rum 40 to 55%, wine 10 to 22%, and beer 4 to 8%. Pharmacokinetics of alcohol. About 80% of the alcohol is absorbed through the stomach, the remainder from the small intestine. It is rapidly absorbed, highly water soluble, and distributed throughout the body. Peak blood concentration is reached in 30 to 90 minutes. 90% of alcohol is metabolized by the hepatic oxidation. The rest is excreted unchanged by the kidneys and lungs. Alcohol is converted into acetaldehyde by the enzyme alcohol dehydrogenase, which further gets converted into acetate by the enzyme acetaldehyde dehydrogenase. Neuropharmacology of alcohol. Alcohol has prominent effects on all neurochemical systems with different actions during withdrawal versus intoxication. Most potent effects are on the GABA complexes in brain, especially on GABA A receptors, contributing to sedating, sleep-inducing, anticonvulsant, and muscle relaxing property. It also impacts NMDA receptors with the dampened stimulatory effects during intoxication and heightened activity during withdrawal. Alcohol acutely increases dopamine and its metabolites. In chronic drinking changes dopamine receptor numbers and sensitivity with related effects on intoxication and craving. Alcohol increases serotonin in synapses, enhances opioid-related brain systems, and impact adenosine, acetylcholine, and cannabinoid receptors. Physiological effects of alcohol. On the liver, it causes alcoholic liver disease. Alcohol is one of the most common cause of chronic liver disease, the others being non-alcoholic fatty liver disease, viral hepatitis, autoimmune hepatitis, and idiopathic causes. There is a wide range of damage alcohol can cause to the liver, including inflammation, fibrosis, and cirrhosis. Severe alcohol damage can lead to portovenous hypertension and decompensation in liver synthetic function, including decreased plasma proteins and impaired clotting. End-stage liver disease may lead to the hepatic encephalopathy, a picture of chronic confusion sometimes associated with the styraxis, that is, coarse shaking of the hands when the wrist is extended. On the GIT, it can cause a gastrointestinal bleeding. Cirrhosis lead to portal venous hypertension and esophageal or gastric varices, which may bleed, often present as hematemesis, coffee ground vomiting, or melena. Less severe is a Mallory-Weiss tear of the mucous membrane of upper gastrointestinal tract caused by vomiting, often secondary to the alcohol ingestion. Alcohol can also be associated with the gastric ulcers. On pancreas, it can cause pancreatitis, pancreatic insufficiency, and pancreatic cancer is also associated with the heavy alcohol use. Alcohol use also inhibits intestine capacity to absorb various nutrients, leading to serious vitamin deficiencies, particularly vitamin B complexes. On cardiovascular system, there is a range of cardiac complications, including arrhythmias, particularly atrial fibrillation, atrial flutter, and ventricular tachyarrhythmias. Alcoholic cardiomyopathy can present with a dilatation of heart muscles, secondary to the heavy chronic alcohol ingestion, leading to heart failure. Other body systems, significant intake of alcohol associated with the increased PP, rearranged lipid profile, and increased risk of MI. On sleep, it can cause a decreased sleep latency, decreased REM sleep, and decreased stage 4 NREM sleep, with more sleep fragmentation, with more and longer periods of awakening. Levels of impairment at different blood alcohol concentration. At 20 to 30 mg per dl, it can cause low motor performance and decreased thinking ability. At 30 to 40 mg per dl, it can increase in the motor and cognitive problems. 80 to 200 mg per dl, it can lead to the increase in the incoordination and judgment errors, labile mood, and decreased cognition. At 20 to 200, 200 to 300 mg per dl, it can cause nystagmus, marked slurring of speech, and alcoholic blackouts. At more than 300 mg per dl, it can cause the impaired vital signs and possible death. Alcohol dependence. Alcohol dependence is characterized by the strong internal drive to use alcohol, which is manifested by the inability to control use, that is compulsion, priority given to drinking over other substances, that is salience, persistence of use despite negative consequences, craving and physical tolerance, that is needing the increasing amount to get the same effect, and withdrawal symptoms, that is tremors, tachycardia, sweating, anxiety, and nausea on cessation or reduction of use. Following cessation or reduction in the use of alcohol may also be present. 3 out of 6 should be fulfilled to call it alcohol dependence. Acute presentation. These will require immediate referral to the emergency services. Most important is the delirium tremens, a severe form of alcohol withdrawal that usually occurs 2 to 3 days after alcohol cessation, characterized by the severe tremors, perspiration, fever, and tachycardia. Can also be associated with a dramatic florid or bizarre visual or tactile hallucinations. Occasionally, hallucinations are predominant and physical signs are less apparent. Other complications are alcohol withdrawal seizures, gastrointestinal bleeding, pancreatitis, hepatic encephalopathy, and spontaneous bacterial peritonitis. Neurotoxicity. Alcohol has a plethora of neurotoxic effects. Central nervous system effects include global atrophic changes, frontal degeneration, and change in personality, and chronic subdural hemorrhages. Wernicke-Korsakoff syndrome. Thiamine deficiency leading to triad of confusion, ataxia, and ophthalmoplegia. Cerebellar degeneration, slurred speech, nystagmus, ataxia, hypotonia, intentional tremors, reduction in the seizure threshold, and withdrawal seizures. Hepatic encephalopathy may occur secondary to the chronic liver disease. Peripherally, alcohol can cause a symmetrical distal peripheral neuropathy. A brief assessment of problematic alcohol use can be undertaken by using the CAGE questionnaire, which is a series of 4 yes or no questions. Have you ever felt you need to cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about drinking? Have you ever felt you needed a drink first in the morning, that is eye-opener, to study your nerves or to get rid of a hangover? 2 yes answers indicate problematic alcohol use and should be investigated further. Further freely available validated questionnaire include alcohol use disorders identification test audit, provides a more detailed measure over the previous year with a score of 8 by 40 or above indicating harmful use. Severity of alcohol drinking questionnaire rates the severity of dependence. Clinical Institute Withdrawal Assessment of Alcohol Scale revised assesses for the presence of withdrawal symptoms, nausea, vomiting, tremor, sweating, anxiety, tactile, auditory, or visual disturbances, headache, disorientation, and rates their severity. Management. Detoxification. Long-acting benzodiazepine substitutions therapy such as chlordiazepoxide or diazepam reduced over 5 to 14 days depending on setting. Nutrition. Heavy alcohol use is associated with the depletion of thiamine, that is vitamin B1, and Wernicke-Korsakoff syndrome. Those with a history of heavy alcohol use should be prescribed prophylactic oral thiamine replacement therapy, 300 mg daily. In detoxification setting and or evidence of malnutrition should be prescribed parenteral, intramuscular, or intravenous thiamine as vitamin replacement due to the inadequate enteral absorption of thiamine. For relapse prevention, a camprosate and supervised disulfiram are used for the treatment of alcohol dependence and may be offered in combination with the psychosocial treatment. Naltrexone is also recommended as an adjunct in the treatment of moderate and severe alcohol dependence. Liver transplant. In UK, approximately 600 to 800 people receive liver transplant every year, with alcohol-related liver diseases the most common precipitant. Patients generally need to have demonstrated abstinence from alcohol for 6 months prior to the operation. These are the references. The Maudsley Practice Guidelines for Physical Health Conditions, Kaplan and Sedok Synopsis of Psychiatry and ICD. Thank you.
Classes. We'll take question of the line.
Good morning, everyone. My name is Dr. Subhar. Moderator is Dr. Shafii. Topic is CKD and psychiatry. Chronic kidney disease. Chronic kidney disease is defined as a deterioration in the kidney function or kidney damage lasting for at least 3 months. Deterioration in kidney function is often identified as a reduction of GFR, usually estimated from blood creatinine. eGFR is calculated from serum creatinine, race, sex, and age. Damage to the kidney may be identified indirectly by identification of blood or albumin in the urine. End-stage renal disease, CKD, requiring dialysis or transplantation. CKD represents a heterogeneous group of disorder. It is common with a global mean prevalence of 13.4% compared with the general population. There is a higher prevalence of CKD in patients with severe mental illness, in particular schizophrenia and bipolar affective disorder. This is likely secondary to increased rates of physical comorbidity associated with development of CKD, such as diabetes mellitus and hypertension, as well as nephrotoxic effect of some psychiatric drugs. The anticholinergic effect of some psychiatric drug can cause urinary retention, which via hydronephrosis may damage the kidney. The relationship between CKD and psychiatric disorder is bidirectional. For example, patients with CKD undergoing renal transplant therapy exhibit high rate of depression and anxiety. CKD is associated with increased all-cause of mortality, although the leading cause of death in this group is cardiovascular disease. CKD is also associated with a number of other complications which reflect diminished endocrine and exocrine function. These include, depending on the severity of CKD, increased risk of acute kidney injury, anemia, hypertension, dyslipidemia, mineral-borne disorder, metabolic acidosis, electrolyte abnormalities, most notably hydrophosphatemia and hyperkalemia. Hyperthyroidism, infection, uremia, symptom complication of which can include pruritus, restless leg syndrome, sleep disturbance, fatigue, sexual dysfunction, anorexia, and cachexia. Bleeding, pericarditis, encephalopathy, and thyroid dysfunction, and increased risk of drug toxicity owing to the accumulation of renally excreted agent. Cause of chronic kidney disease. These are the diabetic mellitus, hypertension, obesity, obstructive uropathy, glomerulonephritis, chronic intestinal nephritis, polycystic kidney disease, autoimmune disease, genetic malignancy. Infection like human HIV, hepatitis B and C, malaria, schistosomiasis, leptospirosis, antivirus, and staphylococcus. Drug toxicity like lithium, non-steroidal anti-inflammatory drug, chemotherapy, proton pump inhibitor, antimicrobial agents, some herbal medication like H2. Stage of chronic kidney disease based on the GFR and albumin excretion rate. G1 more than 90 is normal, G2 60 to 89 mildly decrease, G3A 45-49 mildly to moderate decrease, G3B 30 to 44 moderately to severe decrease, G4 15 to 29 is severely decreased, G5 less than 15 kidney failure. 5 it is treated with dialysis. Albuminuria stage A1 less than 30 is normal to moderately increase, A2 30 to 300 moderately increase, and A3 is more than 300 severely increase. Clinical scenario in which psychiatric practitioner may need to consider chronic kidney disease as a part of the holistic care they provide patient. The first scenario in patient setting is determined whether a patient with raised serum creatinine is presenting with an acute or chronic kidney disease, chronic kidney injury, as this will determine the urgency with which subsequent investigation are performed. The second scenario, inpatient setting, is dealing with the complication of CKD such as electrolyte disbalance or the accumulation of the renally excreted drugs such as lithium. The third scenario, which occurs in the both inpatient and outpatient setting, is supporting patient with the stabilized CKD to reduce the risk of worsening renal disease via control of the risk factors such as smoking, hypertension, and diabetes mellitus. The fourth scenario, again pertinent to all clinical setting, is appropriate prescription of the psychiatric medication in the context of CKD, be the drug that are directly nephrotoxic lithium or those indirectly drugs that are predominantly renally excreted and thus may accumulate, like example lithium sulfuride and amisulfuride, or drug with side effect that may be amplified in the context of reduced renal excretion, example sedative effect of benzodiazepine or anticholinergic effect of tricyclic antidepressant. History. Chronic kidney disease is usually asymptomatic with sign and symptom only arising in the later stage.
You have time allotted is 10 minutes. How much time will it take?
What slide?
How many slides is there?
Sir, 15, 14. Illness, however, non-specific symptoms such as lethargy, nausea and vomiting, anorexia and pruritus may occur, and some symptoms may point to specific renal urinary pathology such as loin pain, hematuria, change in the urinary frequency, and porphyria. In terms of past medical history, other than determine if there is pre-existing CKD, inquire about the presence of the comorbidity and risk factor for CKD. Scrutinize medication list for any agent that are associated with kidney damage, for drugs that may accumulate in the context of renal dysfunction, and for drugs that may be harmful in CKD. In terms of drug accumulation, psychiatric medication to be particularly aware of are lithium, amisulfuride, and sulfuride. Take a family history for CKD and polycystic kidney disease and social history for smoking. Alcohol intake and recreational drug use. Complications of the latter include glomerulonephritis and amyloidosis in intravenous drug user. Renal failure secondary to rhabdomyolysis with use of cocaine and amphetamine, for example, and renal artery atherosclerosis for cocaine use. Examination. The purpose of examination is to rule out complications secondary to chronic kidney disease, and etiology is unclear, and identify potential causes. The set of basic observation, including blood pressure, may identify comorbid hypertension, and low oxygen saturation may indicate pulmonary edema. Abdominal, cardiac, and respiratory examination should be performed. General inspection may provide evidence of fluid overload, shortness of breath, means peripheral edema, anemia, conjunctivitis, pallor, or the accumulation of the certain drug. Example is tremor in context of lithium. Cardiac and respiratory examination will again screen of evidence of fluid overload, raised jugular venous pressure, crackles, and auscultation of the lungs. Abdominal examination should inspect for masses which may indicate polycystic kidney disease, or for a distended bladder in a male patient is chronic urinary retention. General inspection may identify feature of other systemic illness associated with CKD. Example is rheumatological disease. Investigation. The following tests may be considered by a psychiatric team will be ruling out acute life-threatening presentation that may accompany CKD. Example is hyperkalemia, but will also strengthen a referral to renal colic, especially if the etiology of CKD has not previously been investigated, like blood, urea, electrolytes, bone profile, liver function, full blood count, like anemia, HIV, hepatitis B and C, HB1AC, autoimmune profile. Urine, deep urine for proteinuria and hematuria, measure urinary albumin and calculate the albumin creatine ratio. Consider sending urine for microscope. ECG examination for consequences, example hyperkalemia or causes. Example, left ventricular hypertrophy or hypertension of CKD. Imagine an established investigation. In this is a new presentation of CKD with no previous investigations. Consider referring the patient for ultrasound of the kidney and urinary tract, examining for any structural abnormalities. If appropriate, renal physician may require to perform established investigations such as MRI of kidney, examining for renal artery stenosis and potentially renal biopsy if etiology of CKD remain unclear. General principle when prescribing psychiatric medication with CKD as follows. Psychotropic and other medications should be rationalized to minimize to risk direct nephrotoxicity. Decision to continue.
Can you brief it up? Yes, this should be reading the whole slide. Can you give the gist? Brief it up. ठीक. Continue.
Continuing lithium treatment, especially when GFR drop below below 60 ml per minute per 1.7 should be made following this benefit. There is a risk of drug accumulation, including accumulation of active metabolites. In patients with CKD, as such drug substances will excreted, example lithium and amisulpride and sulfide. These are the table for special consideration when prescribing antidepressant, antipsychotic, and modafinil. Antidepressant specific evidence for use of CKD with bupropion, citalopram, and acetopram. There is no specific dose for antidepressant drug. Citalopram or through monitoring for QTc prolongation, and antipsychotic monitoring anticholinergic hypotension and sedative effect of antipsychotic. Most antipsychotic can be used in severe CKD, although with all antipsychotic caution is advised. Start with low dose package. Low dose olanzapine also bear metabolic side effect or alcohol. Mood stabilizer. Long-term treatment with lithium may cause progressive irreversible impaired renal function. Apart from lithium, no specific dose adjustment are advised. Low dose lamotrigine with updated as required. Diminished drug clearance in CKD increase the risk of side effects with certain medication, example like sedation and confusion with benzodiazepine. General principle of chronic kidney disease: manage reversible cause of renal impairment, example nephrotoxicity drug, especially non-steroidal anti-inflammatory drug. Control the risk factor, example glycemic control in diabetes and pressure control in hypertension. Manage the complication, example anemia, and should we manage the secondary care in people with stage 3 and 4 CKD.
You all these speakers. Any questions? Yeah, actually technical should be strictly technical. I wish you should moderate. You can ask to moderate their sessions for a purpose, so that the presentations are more focused. So the questions. So is alcohol healthy? Even 30 ml of alcohol per day is not healthy. Huh? Any references? And what is the psychogenic overactive bladder? Overactive bladder. A lot of patients will come to us that they'll go to frequent urination, maybe multiple times in a day. They don't have any infections.
Due to psychological cause, the patient has multiple time urge to urinate in a day. That is frequencies more than
One thing I appreciate is that clozapine can cause retention at the same time incontinence. And what do you do then when you stop lithium? When you stop lithium, what stage of chronic kidney disease you say that we should not be lithium? Less than kitna? GFR or EGFR? EGFR is different from GFR, right? कितने से कम होना चाहिए? Less than 60 is mild to moderate. It is mild to moderate. You can check.
Mild.
You also have presented, have you read your presentation? Huh? How much time did you take? You all three to prepare the presentation? Hmm? 6 hours you have dedicated to the presentation. 3 years. Overall 3 years you have given to the presentation. Any questions? That was good. Check it. Then if you can not absorb from studying, you can do it. And how it is metabolism? And what is Meo's pathway? The alcohol is something you will deal with subsequently in interaction with. If someone who wants to become a nephrologist, he will come across these kidney issues. These are very important. Third presentation, we were very interested because that's a very important part. You basically will learn how to present it and write so many things in the slide, puts the audience off. You tried well. You have to write around 6 to 8 words per line, around not more than 6 lines. 6 by 6 rule, we say. And the background either should be preferably white and written text should be in black, or either way. Background should be in black, the preferred text should be in white. But how you select background? How you select background? Background is selected on the basis of your presentation room. Okay? So if your room is well illuminated, so white background and black text, colored written text works well. If the room is not illuminated, if you darken the room, the presentation, the hall, they switch off the lights, then better is go for a black background and a white color text. So it catches the audience better. Photographs, very briefly written. Then you need to remember, because you are not given so much of time to the presentation, 3 hours, very less time. First write up, you paste everything, then read by yourself, then see whether I am in the audience, whether I'll be able to take it or not. How I'll be in the audience, how I'll take this information. What interests me, what are the interesting points? Let me just briefly crisp it up. Prepare it, rehearse it 3 or 4 times, and then present. Anyways, you all will learn. Internship, I don't know, we didn't present anything in internship of this sort, so it will be learning. It's too much to expect, but you want to learn and subsequently progress. Okay? So you can just go there. Just listen. And what we presented is important. The EGFR and albuminuria is important when we talk about taking a decision whether kidney dysfunction is happening or not. It is not isolated EGFR. Do you want to stop lithium or not? So you say lithium causes CKD. Yes or no? Huh?
Yes, I think.
You say
No,
causes CKD.
No, like
Hmm?
there is no like lithium can't do.
Lithium causes CKD. Yes or no?
I think
Please. Okay. Yeah, yes or no? Okay, whether lithium causes CKD or not. बहुत लोग पेशेंट लोग इंटरव्यू करके आते हैं ना, नहीं, it is associated with chronic kidney disease. Association is not causation. And many times they say that CKD happens, it just unfolds it. So it's just an association. Psychiatry में वो multiple associations मिले. That doesn't mean that it causes it. Causality is different from association. Lithium causes? करा सकता है. But again, causality नहीं है, but associations. People have not established now. Thyroid जैसे है, thyroid में goes and gets accumulated. So वहाँ causality established. Causality के सारे parameters हैं. Then you can say it causes. Very few conditions in psychiatry, the drugs are directly having evidence of causality. Maximum it is associations, and that is why they are being implicated in a wrong manner. No one would implicate your tennisat and with kidney dysfunction. What happens? We monitor kidneys. So, वहाँ तो वो मना कर देते हैं. हमारे तो लिखे नहीं. So, congratulations to the second speaker. Congratulations. कॉन्फिडेंट होके बोलना है, कुछ नहीं है, क्या है? Thank you. We'll do a very quick round.